CTs and MRIs and everything.
Mm-hmm.
And I know you've been through a lot of treatment from a very young age. And the short story is that I basically agree with Dr. Patel. I personally, if you were my patient, I would not recommend more chemotherapy, because when they did the surgery in late August, they took that out again. It didn't show any treatment effect, meaning that the previous radiation or chemotherapy did not kill those tumor cells.
Yeah.
So they got it out. There was negative margins. That was very important. But we know that when we're evaluating how useful or how effective is the chemo, we look for what's called necrosis at the time of surgery. And yours didn't show us that. You want to see at least 90% necrosis. So anyway, because of that, I wouldn't pursue chemo. What I would do, they'll talk to you about what can we do for this. There's two basic options. But as far as after this workup, whether it's surgery only, whether it's radiation and surgery, after that, I would pursue a clinical trial where we use some kind of other new combination of medicines that's not, VAC, basically, not the dactynomycin, adriamycin, and cyclophosphamide that you got before, that you've gotten twice now. Does that kind of make sense?
Yeah.
What questions do you have for me kind of right now about the role of medications, of either chemo or other medications?
So the new medicines you're talking about, like, is it like chemo or is it something else?
It depends. The clinical trial that I would probably favor, it's going to be opened up here in a couple of months. It's one chemotherapy drug and one drug that is, it's a targeted therapy.
Yeah.
They're both oral, they're both pills, so you don't have to get stuck with the infusions of long chemotherapy or get admitted to the hospital. They're pretty well tolerated. There are still side effects.
Yeah.
Okay, like you feel tired, you might get some nausea or diarrhea, things like that. But overall, it's easier than just like 3 or 4 chemotherapy drugs. And you take these pills, and we would still watch the same way. We would get another scan after 6 weeks, 2 months, and make sure that it's working, make sure that you're tolerating it okay, things like that. And the reason I say a clinical trial rather than more chemo is, again, because we have to look at previous response. This has come back twice, and in spite of getting a pretty good amount of chemo already. I know you're young, and chemotherapy sometimes can increase the risk of getting another type of cancer, like in the bone marrow, like a leukemia type of thing, over time, after 5-7 years, something like that. So I don't want that to happen either. And there's new drugs coming out all the time. If there's something new coming down the pike that looks promising, and it looks like it's very good for this particular type of sarcoma, then I would prefer that. But for
Good
now,
morning. The television system will be temporarily out of order. The television systems will be temporarily out of order.
But for now,
the loudest announcement I've ever heard them make. Must be the most important thing they've ever had to announce.
TV.
And so I summarized everything that you've gone through, and then what my basic kind of recommendations would be. But we have a decision point here about what exact approach do we want to do. So you can speak to that.
Could I ask you a couple of questions about your radiation? First, where did you get it? Who gave you radiation?
Well, the clinic is in Green Bay, and then it's just basically my calf.
Okay. So it was all below your knee?
Yeah, they just did the exact surgical area.
Okay.
Yeah.
And it was after your surgery?
Yeah, it was like a couple weeks or month, at least a month, or not a month, but like until I recovered.
Yeah.
Until my whole skin just fully healed. Yeah.
And that was back in the fall, right?
Yeah.
Okay. So we So the area, and can I feel where this mass is that you're
Yeah.
feeling? Yeah.
Right. On my finger.
Yeah, small little marble. You must have been kind of hyper aware to feel anything there. Were you having any pain or symptoms?
Well, at first when I was exercising like a few months back, I felt pain there,
Okay.
and then I just decided to feel that area, and I felt something.
Do you think the radiation came up as far as kind of this high?
Yeah, when they put the gel on,
Mm-hmm.
like the customized,
Mm-hmm.
man, it was just so big. It wasn't like all like
It was the back of the time.
yeah.
Okay. Okay.
And this side, just for comparison. How was the wedding?
That's good.
Good.
Tiring.
Was it this weekend?
Yeah, it was this past weekend. Oh, what was that?
Who got married?
Oh, my brother. Sorry about that.
Oh, great!
Yeah,
Congrats.
that's my brother.
So we were just starting to talk about, Dr. Panta just said that he wouldn't recommend using the same chemotherapy, and they talked about kind of clinical trials and other options. And we were just starting to talk about radiation. All of his radiation was after his surgery, and he hasn't, and that was just in the fall. So on the one hand, it's really too soon to know if the radiation worked, because there's just hasn't been a lot of time for this to potentially have come back in that area. On the other hand, we've never treated visible cancer with radiation, so again, we still don't know whether radiation is effective for your tumor. We know that the original chemotherapy seems not to have worked great, at least when we looked at it under the microscope. It didn't show that necrosis that he was saying. Doesn't mean that it was a waste, doesn't mean that it didn't work at all, but it didn't show what we really want to see. So it may be that radiation may still be effective for the area that we're seeing now, where there are kind of masses that we want to treat. And I do think it would most likely be feasible for you to get more radiation, because it's a separate area. It sounds like everything was down here, and this is definitely up to Vasa and would be going up. So that's I think would be feasible for you to get more radiation. It would generally be a higher dose, because we're treating the disease that we can see instead of trying to kill some microscopic cells that may or may not have been left behind after surgery. But it would be something that would be kind of incorporating into an overall treatment plan. It would be a potential either alternative to surgery, a potential way of making surgery easier before surgery, or something that we could do after surgery. And so it's something we have to kind of put together with everything. We could treat it, as a definitive if we wanted to.
Mm-hmm. I don't. Did you guys chat about trials and things, or?
Yeah,
Okay.
but not surgery.
Yeah, and I know Dr. Patel I probably gave you the impression just need to get these things out,
Yeah.
right? And so I just think we're chasing it a little bit, and we can chase things and we can potentially catch it, but I don't want to get to a point where we're chasing something and then all of a sudden it's in your groin or in your abdomen or in your chest. Because one of the options for this is going in there and removing those things, but it's not just like taking out a little marble. They're very close to a blood vessel, and they're probably not real hard, like you could feel this and just take it out. It's in an area. So if we could get that to shrink away without having to do any surgery, that would obviously be the best case scenario. So I think it's worthwhile considering a trial where maybe if there are other little cells throughout your body, because these weren't there before, and now they're there, and they're not where your tumor was. Sometimes when things come back like this, especially a third time, we talk about doing an amputation of your leg.
Mm-hmm.
And I'm not sure that that's something we want to do unless it's absolutely necessary. Did Dr. Patel say what he thought the surgery was going to be?
No.
Okay. So before we get too far ahead in saying we have to do something very aggressive like that, I think we have to make sure every single option is at least discussed. So I think it's worthwhile having you see the pediatric guys who treat this. We treated you with the what's called a pediatric protocol, but it's worthwhile just getting another set of eyeballs on this, I think, if you're okay with that.
Yeah, there's a specialist at Children's, Dr. Meg Browning, and they have a couple of trials going that you can just sit, sort of talk to them like a consultation and just see if they make sense, if it's something that you would like to pursue. In the meantime, we wanted to probably biopsy this right groin again. You had a biopsy about 3 years ago from the right groin. There was a lymph node that kind of lit up on the PET scan. We weren't sure, and it did not show cancer at that time. But especially before surgery, especially before considering an amputation, we want to make sure that that's not cancerous still. Just like in your neck, that thing was biopsied too, did not show cancer. That thing looks better, actually. We don't think that that's cancer. These guys are about the same, so we just wanted to make sure.
Do you feel anything there that's been growing?
Yeah, I actually do. I felt like I can feel it right now. And I'm not sure. Can I feel it? Yeah.
Okay, that'll be very easy for them to biopsy.
And
So this was there before, but it's bigger now?
I just noticed it.
Yeah, I don't remember that being there when I saw you last. Was it there? Maybe I can't remember if I checked or not the last time
sorry. And then we'll send it for, obviously just to pathology to look at it, but we'll also send it for testing.
Yeah.
We had done that on a previous biopsy. Didn't show us a whole lot of options, but sometimes there's a particular change in the tissue, a gene mutation or expression
And I'm gonna
that
put it in there.
that can point us in the right direction for what kind of treatment would be best to kill it. So I would definitely want to send it for that analysis. So Dr. Patel will get all of our thoughts and recommendations, I'm sure. But as far as all the management, all the treatment that you've gotten, I think I would have done the same. He's spot on. He's got a lot of experience. We all know Dr. Patel, and he's treated very aggressively. I think you've had a really just terrible luck with this. But we're not done. We're here, and you're in the right place. You're in the right hands because you of course want to continue getting managed by a trained surgical oncologist, orthopedic oncologist, and radiation oncologist, with obviously Dr. Powell.
So the most important thing is to try to figure out, like Dr. Ping was saying, what we can get to get everywhere in the body, because like Rob was saying, it is kind of marching, and we can keep, plucking bits out, but we're always going to be behind the 8 ball, because there's always going to be microscopic cells that we can't see that may come up outside of what we take out. So we want to find something that can get to everywhere in the body. So that's why we're kind of starting with the idea of a clinical trial.
Yeah.
But we don't think, just like before, we don't think that that's necessarily going to be enough. Where, just like before, we would recommend some kind of local therapy right at the spots that we can see, and then that could take multiple different directions depending on, how aggressive we want to be with the surgery, how morbid the surgery be, whether we want to do radiation instead of surgery or in addition to it. So there are lots of different options for that. That is to some extent less important. We're weighing pros and cons of all the approaches, and it's kind of it's a adjunct to the idea of getting some systemic therapy.
So like I'm wondering is the tumor started here, so it's just slowly going up, or does everything start here, and that's that why my muscles are just reacting up the tissues and whatnot?
There are lymph nodes that go up, and so it may be that it's in those that.
It's acting kind of funny. So it usually doesn't go like this, but it really seems. And they didn't think it was a lymph node in the back of your knee, although I'm not 100% convinced that that's not a lymph node. in the back of your knee. In fact, I think it is, but that doesn't matter. What does matter, very importantly right now, is that we get a sample of that node up in your groin, because that doesn't feel right. Now, can that be reactive because of your leg? Absolutely. It definitely can. But we have to know that 100% before we start on the next portion of the treatment.
Yeah, because if we were to like amputate this, do you guys have a percentage on why there's like these are causing?
That's right. So that's if we needed to amputate that, and I could say, if we amputate this, there is a 90% chance that this won't come back, or at least an 80% chance. I would say let's do it. But because the way that this is acting might go right up a lymph node, and just because we take off all the tissue and the bone below that, that doesn't mean there's not a cell that's up there right now growing.
Yeah.
Because if there's a cell up there growing and we amputate down here, then we have done the wrong thing. And that we're not going to do the wrong thing.
Yeah.
Now, is there going to time we might have to talk about percentages of getting it right and wrong? Yes. But right now, without more information, that is not the right thing for you. That's not what I would do for my son, myself, any of these guys, even people, that it's not the right thing right now.
Okay.
But the right thing is to get a sample of this tissue to see what else we can get you on and go from there.
Okay. Yeah.
So what we'll do is we'll put in a biopsy of this to be done up in Green Bay, and then they'll call you to get it set up. We'll also put in a referral for Dr. Browning over at Children's.
Okay.
They'll call you about that too, so you don't have to do anything right now.
Yeah. And so this is basically surgery is not scheduled yet, because you guys, I know from what you guys all saying, you guys are still talking and
Yeah,
really
we'll be
discussing.
talking to you too, so you just continue on with your life. And surgery's not going to be all of a sudden like this or anything.
Yeah.
However, if we talk, once you see Dr. Browning and everyone puts their head together and they say that surgery, we'll do it right away, but now is not the time.
Okay.
Especially now, not until we know what that node is.
Yeah. And let's see. I know I'm still communicating with my hyperbarics doctor.
Yeah.
Yeah, so I'm still doing that. Can I just continue doing that
Yeah,
too?
do that definitely.
Yeah.
Yeah, continue doing everything else that you're doing, including enjoying your summer or working, whatever you're going to do. Just keep doing that.
Yeah. Okay.
So, and we'll get the biopsy, the right lymph node, right groin lymph node biopsied again, and have more info. I think then we're closer to a decision.
Okay. Yeah, sounds good.
And every time you come back to St. Luke's, I'll see you here.
If there's any questions, keep communicating with Jennifer, and she'll get things set up. But you'll be hearing from her on both of these things.
Okay.
Okay.
Yeah.
Parents okay?
Yeah,
Okay,
I know. I told them that to save their dates for the surgeries, because I know they can't take off all the time.
Yeah, don't worry.
So I was like, yeah, I'll just come alone like most of my visits. So
Yeah,
I'd rather have them save their dates.
I think you understand things very well. But if they have questions and they want to call,
Okay.
they're welcome to call. I'm happy to talk to them. It's
Yeah.
no problem.
Yeah.
Okay?
Yeah.
All right, we'll be in touch with you.
Okay, super.
Hang in there, my friend,
Yeah,
okay?
Thank you.
All right.
Appreciate it. So,
Good to meet you.
good to have a great day.
And who is your radiation doctor out there?
I think Vanderwall.
Oh,
Dr.
okay.
Vanderwall.
Okay. I know her. She works with me. I'll just give you my card so you know who you talk to down
Okay.
here, and then
Yeah.
we'll make sure that they know what's going on with you.
All right, sweet. Thanks.
Thanks.